From the heart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, this is Bob Harrington from Weill Cornell Medicine in New York City, here on Medscape Cardiology and the heart.org. This is one of my favorite shows of the year. Well, we usually do it at the end of the year, but now we're doing it at the beginning of the year. And I'm going to be joined by my friend Mike Gibson. And the opportunity today is really to give a look back at some of the key cardiology trials, some of the happenings in cardiovascular medicine in 2024, and then use Mike's time to look ahead in 2025. So joining me here is my longtime friend and collaborator, Dr. Mike Gibson. Mike is a professor of medicine at Harvard Medical School. He's an interventional cardiologist at the Beth Israel Lahey Medical Center in Boston, and he is the CEO of the BAME Institute, an academic research organization. Mike, once again, thanks for joining us here on Medscape Cardiology for both our wrap-up and look-ahead show.
Welcome to 45 times 45, 2025.
I like that. I thought we'd break the show into two parts. Let's do some of the key trials, which I think kind of set the theme for the big things we were learning in 2024. Then we'll turn our attention in the second half of the show to what's ahead. So trial number one I want to talk about is the Reduce AMI trial. To me, this was a really interesting trial, Mike, in that it took an old concept, something that we had done for years, which is that everybody post-myocardial infarction had to get a beta blocker, and tested the question, is that really true? What'd you think?
It was true when we were fellows. I don't think it's necessarily true in 2024 and beyond. There was really no difference in the clinical outcome. But keep in mind this, Bob, this was a mix of MIs. This was both STEMI and non-STEMI. So,
and mostly with pretty good ejection fractions.
Yeah, with an EF greater than 50%.
Yeah.
So this does not apply to those patients who have an EF less than 50%.
Right.
65% non-STEMI. The other thing I thought was somewhat discouraging was it was an open label study. That's the kind of a theme of some of the studies we're going to talk about today. A lot of them are open label, which really makes me a little concerned. And it was a little underpowered. I mean, they were expecting about a 6% annual event rate and had about a 3% annual event rate. So they really didn't hit the numbers they thought they would. So important to keep those caveats in mind. Another thing that struck me was they really under-enrolled women. That's a real problem we're seeing in a lot of our post-MI studies.
You and I have talked about this a lot, particularly with our mutual friend, Roxana Moran. You can't just assume that things that work in men are going to work in women or vice versa. You and I are involved in a bunch of trials where we've struggled in many ways to make sure that we have adequate representation, adequate enrollment of women. And that's a challenge for clinical trials for a lot of reasons. And it's something that we as a community have to continue to be focused on. What are you doing in practice now, Mike? You still do, I know, take acute angioplasty call, et cetera. Are you no longer loading them up with beta blockers because of trials like this?
No, I don't think so. I think my practice has definitely changed, particularly in this group of people, EF over 50%. But again, for the low EF people who have some heart failure, these results do not apply to that population.
Another theme I think that emerged from this last year is thinking about older trials, older practices, and when do you have to update things? I was talking to somebody recently about bypass surgery and, still making the point that the trials where we demonstrated the benefit of left main disease undergoing CABG, these are really old with essentially no medical therapy. And what does that mean in a contemporary era? And what does that mean with contemporary medical practice? This gets to that question that a lot of us talk about, which is the continuous cycle of evidence generation, and we just don't have that.
What we do, Bob, is we add medicines on top of other old medicine. Yeah. Aspirin is a classic example. So we had aspirin, then we had clopidogrel, and clopidogrel was better than aspirin. What did we do? We added clopidogrel to aspirin rather than replacing aspirin. And now, fast forward 20 years later, we can now see that ethionopyridine probably is superior to aspirin plus ethionopyridine. So you're right. We have to reassess as we have new strategies, and we need to be able to replace things
Yeah.
rather than just add things.
You and I are involved with a clinical trial looking at a factor 11 inhibitor, and you're leading the component in acute coronary disease. And we're definitely adding there, aren't we? We're just saying if you're on one antiplatelet therapy, if you're on two antiplatelet therapy, it doesn't matter. We're going to enroll you anyways. And really, wouldn't you like to know, is it anticoagulant, is it antiplatelet, or is it both? That's really the kind of question that you'd like to know.
I'm so disappointed. I mean, we've had years of studies now where less is more, taking away, some of the antiplatelets reduces bleeding, but doesn't really put you in ischemic risk. But here's the crazy thing. We still have 95% of people getting DAP through a year. Guidelines got to keep up with the data.
Well, and you remember when we were planning this particular trial, we agonized over the notion of how many people are going to be on DAP? How long are they going to be on it?
We thought it
And
was over. We thought DAP was over.
it clearly in the practice world, and people who participate in clinical trials are pretty sophisticated as a group of clinicians, and still we're seeing a lot of DAP use. Let me go to another old idea, although we have new methods for looking at it, and that's the PREVENT trial. You remember Rick Kuntz's idea of stenting the entire artery as a way to prevent future coronary events. People said, no, you don't want to do that. And he had some elegant angiogram data that suggested that might be the thing to do.
That elegant angiogram data came from yours truly, who
Yes,
sat
it did.
and measured the distance from the ostium down to the stenosis. And most everything is in the first 20% of the vessel that causes a STEMI. So you wouldn't really have to stent the whole vessel. You just have to stent that very vulnerable region, which turns out to be the proximal part of vessels. They took, about 1,000, 1,600 people who had a lot of plaque burden greater than 70%. They couldn't be flow-limiting stenoses.
Yeah, and they had to do FFR.
If you do FFR, they had to be lipid-rich. And that's one of the things, this was done in the Asian countries who do a lot of intracoronary imaging. And so that may not apply to the US where we don't do as much of this imaging. So it's not just a stenting strategy.
It's combining the imaging with the procedural strategy. Yeah.
It's people who are very good at imaging. The other thing about Asia is they have a lot of fish consumption. They had a lot of antiplatelet use. And the fish gives them that omega fatty acids that have a little bit of an antiplatelet effect. And for reasons we don't understand, stent thrombosis is less frequent in Asia. They saw very good results. It was like a 10-fold reduction in events, down from 3.4 down to 0.4%. That's very good. Similar results maintained, maybe not as big as the relative risk reduction, similar absolute reduction out a few years later. So provocative, very consistent with, I submitted grants to do this years ago. No one would fund it. But it makes you wonder, are we replacing vulnerable plaque with some stable plaque there with this approach?
Well, and then the other thing that really caught my interest was that, yes, it's intra-procedural imaging, but now, as you know, CT imaging, CT angiography, photon CT is getting to be a pretty powerful technology to look at plaque non-invasively and to start to be able to quantify how much vulnerability might be in this plaque, and might you be able to even pick out ahead of time and give you non-invasive equivalent of FFR. So if you can get it all, the flow, the plaque characteristics, then maybe you can go in there and stent in a very directed way. Is that crazy?
The leaders in this field now are using AI to really characterize the plaque constituency and characterize, is it fatty or not? And so knowing where it is fatty or not, we can do some spot stenting. It's a wonderful hypothesis that really
It's worth testing, isn't it?
testing.
Yeah, and the other thing that is we talked about when you and Rick and others proposed these notions years ago, we had a very different type of stenting platform.
Yeah.
Now we're talking about much thinner stents, much less risk of stent thrombosis, better antiplatelet therapy. So we got a lot of other things going for it.
33% were bioresorbable in this study.
Although if I remember right, didn't it look like the metal stents were better than the bioabsorbable stents or had a bigger effect?
It depends. I mean, Early on, the bioresorbables had a little bit of a hazard, but a couple of years later, the curves inverted. So the bioresorbables did better late, which is kind of what you would hypothesize, because once it's gone, you have normal vessel there. And that may be a normal functioning vessel, may be pretty good over the long haul. One other caveat, this was unblinded and driven a lot by revasc.
This is going to be a theme, isn't it? We're going to talk about one of the TAVR studies later on. And this unblinded nature in a device trial is always, it's problematic. It gets into the whole issue of shams. It gets into surgical therapy versus interventional therapy. It opens up a lot of questions in clinical study design. Mike, let's move away maybe from a specific study and talk about an area that I know you and I actually did a TCT session on this, GLP-1. It's sort of like the era where every statin trial just seemed to teach us something new. Now we're seeing GLP-1s and wow. What's your sense?
We've had a lot of diseases. We had athro, we had hypertension, we had diabetes, arthritis, and these were all diseases, but they're part of a syndrome, and that syndrome is called obesity. And I'm going to go out on a limb, and I'm going to say, since we had public sanitation, antibiotics, some really revolutionary things in healthcare, I think this is going to be amazing for public health.
Wow, that is a big statement. So you put it up there with big changes in public health.
This is a disease of lifestyle. It's a disease of, 40, 60 years of being obese. We talk about LDL years. I think someday we're going to be talking about pound years. We're going to be talking about BMI years. This is a cumulative effect of this syndrome. I think we also got to change from viewing it as a moral failing to a disease, a complex disease. The results are all consistent. What's really fascinating,
Like fascinatingly consistent.
yeah, but what's fascinating is the mechanisms, and some of this is probably going to be mediated centrally by dopamine and positive feedback loops. I'll be honest, I took them. I lost 30 pounds and I kept the weight up. All my numbers came down. LDL came down. My LDL is 27 now with different drugs. Your hemoglobin 1 comes down. Your blood
Pressure.
And people wonder, well, why are the curves diverging so early? They're diverging so early because you're treating every single modifiable risk factor. And even maybe smoking, because some people stop smoking.
Not just stop smoking. People stop consuming as much alcohol. They stop gambling.
I didn't drink much before, but I don't drink at all now. I mean, it's just fascinating. You just have no desire for those types of things. So I think it's going to be revolutionary. What's fascinating is the battle in the marketplace seems to be over who can get a 25% weight reduction. And if you don't hit 25%, you're kind of dead in the water.
Yeah, there's a recent trial that missed 25%. And even though it looked like an impressively positive clinical trial, the criticism was just as you said, that it didn't hit 25%. So what does that mean?
So do we need 25%? Well, maybe in the induction phase. But what's kind of being ignored is the kind of maintenance phase. And there it may be a whole different ballgame. Really what we want there is tolerability, no side effects. You don't need to keep losing 25% of your body weight. It's going to be interesting to see how things shake out. I think side effects are going to be a big driver of clinical success.
Well, I think there's a couple things, right? First, people have been talking about this on-ramping and off-ramping. So you're calling it induction and chronic maintenance. And it brings into cardiovascular medicine some of the lingo of cancer drugs, doesn't it? I mean, in addition to the side effects, which people have talked about, the GI side effects, the dyspepsia, there's also some side effects with skeletal muscle loss that people are concerned about. And
it's a little confusing. You have a little fat in your muscles, and if you lose the fat between the muscle cells goes away too. The real question is, how about muscle function?
Yeah.
And muscle function seems to be pretty well preserved, but there's a little bit of data both ways there. That's still kind of playing out.
Let's keep an eye on the class. And I suspect, as you and I talk about looking ahead in 2025, this will be a topic we're talking about.
Absolutely.
The next trial, which I found is sort of as somebody interested in big trials, public health, big global problems. The blood pressure remains a global problem, and BP Road. large clinical trial done in China that asked that very simple question: is, sort of intermediate level of blood pressure control versus really tight blood pressure control of less than 120. What'd you think of that trial?
A big trial, talking about 12,000 patients, and 6,000 and some randomized to getting it down below 120 and 6,000 randomized to get it down below 140. And getting it down to 120 really gave you about a 25% risk reduction, and that makes sense. I do think, there's a U-shaped curve, to be sure. Lower is not always better, but getting to that kind of set point of around 120 to 100 looks like it's a good idea.
It really does, doesn't it? It was great to see this trial coming out of China where blood pressure is a really big issue and contributes to a lot of morbidity, particularly and mortality, particularly through stroke. It's been said that if you really want to change the globe's public health quickly, control the globe's blood pressure and get rid of tobacco. You do those two things and you have a major, major influence on global public health. So this is one of them. Let's get people's blood pressure down 120. Now, these are specifically people with diabetes, but I think most of us are saying this applies. Let's get blood pressure lower. And your point's well taken. You don't want to go so low that you're dizzy, falling, having the complications of that, but you want to go low.
Yeah, there were more people who
Yeah.
had some symptomatic hypotension. Got to watch out for that. A little more hyperkalemia. I think those things can be managed. Again, the theme here is open label study again. I wish we had more blinded studies. That was disappointing to see this year.
It is disappointing to see it, particularly in a trial like this. We know how to blind these things. There is an expense, right? Because you're measuring blood pressure, but all of that, but it can be done. It can be masked. There are ways to do this. Mike, two more trials I want to cover. Early TAVR, you made reference to the fact of how difficult it can be when trials of devices are not blinded. We talked about a strategy in Prevent. Here we're talking about a strategy. If you had severe but asymptomatic aortic stenosis, you got randomized to immediate TAVR or early TAVR versus TAVR only if you needed one, so to speak. Trials positive from the primary endpoint, but big criticism was that the primary endpoint included unplanned hospitalization. And 50% or so of people who were in the deferred arm, the surveillance arm, I think they called it, ended up getting TAVR within the first year. So what did we learn here, Mike?
Well, first of all, no difference in death, and numerically a few fewer strokes over in the early TAVR arm, but didn't differ. But this is again what happens in these kinds of studies, Bob, is it becomes more of a matter of a strategy. Is an early TAVR better than a late one? And when the endpoint is you got a TAVR or hospitalized, it kind of dilutes out, our understanding truly even of the timing of the benefit.
Yeah.
Obviously unblinded. It wasn't a sham controlled trial, but it looks, like it's reasonable to intervene early.
Other criticism that came in on this one was about no surgical arm. What do you think of that?
Well, that's very true. This is, you're getting a TAVR. It's a matter of when, and it didn't compare it to surgery. The other question is the durability. The follow-up wasn't that long, and, you may have better durability with a surgical approach. So that's a good criticism. And also duration is another limitation.
Yeah, and with surgery, it's always, in terms of the follow-up, if you're gonna have surgery as an arm, you have to have longer follow-up because with surgery, you almost always have the early hazard. The classic example is if you look at the early CABBAGE trials, if you only compared things to 30 days, CABBAGE loses.
Yeah.
It's the durability over time that really makes the difference. So you have to take into consideration the early hazard. It is too bad they didn't have a surgical arm, but certainly it's intriguing that maybe earlier is better.
Well,
And
Bob, we're doing a bad job on long-term follow-up of these
yeah,
devices. And I'm proud to say here at Bain, we have developed a registry. We've completed building it so that we can follow people up to 5, 10, 20 years. We're going to go direct to patient. We're finding that people will fill out these forms. So we've built it so that you get randomized. You'll be able to get followed up every year, all the way out through 20
yeah.
years, so that we can have this long-term data because it's really missing at this point.
You know, it's interesting. During COVID, when we all got our vaccines, we were being tracked by our iPhones, right? I would get a message said, "Hey, can you provide us a little bit of data?" And I find that most people who have had a medical procedure, who are on a therapy, who have some syndrome, they're happy to give you their data as long as you can tell them that it's going to be used for something meaningful, like trying to get insight into the world of their thing.
Well, and if they can improve the lives of everybody and others, I guess we were dumbfounded in the Apple study that the reason people participated was really altruism. They wanted
Yeah.
to compare.
Last trial to talk about before we turn to 2025, Mike, Oceanic AF. And again, I'll declare the conflict for both of us. You and I are involved with a series of clinical trials with another factor 11 inhibitor, trials that are still going on, including in the AF space. Oceanic, interesting study, large study done with Asundexian, one of the factor 11 inhibitors that was presented at the ESC meeting last summer, and a trial that was actually stopped early by its DSMB because in the comparison of the novel factor 11 inhibitor against the standard factor 10 inhibitor, apixaban, there was an increased risk of stroke in the AF group, in the factor 11 inhibitor treated group compared with the apixaban treated group. A lot of discussion, Mike. Is this a class effect? Is this a specific drug effect? Was this a dosing issue? What is this?
I have a conflict. I do receive grant support from every manufacturer, factor 11 inhibitors, and I wrote an editorial about this in Jack. You know what? Was it the wrong hypothesis, wrong dose, wrong patient? Wrong hypothesis. Um, when you measured the factor 11 levels, the people with and without an event, at least using the Bayer assay, did not differ.
Right.
So that makes you wonder, is there anything related to the factor levels? Now, very small numbers of patients in that sub-study with events, questions about the assay. Was it the wrong dose? The dose is 50 milligrams once a day with high peaks and low troughs with asundexian versus, say, twice a day with milvexian, where you have a little lower peaks but higher troughs at a 4 times higher dose. So we'll test the hypothesis. We're looking at something that has higher trough levels at a higher dose. We don't know yet. We will see. Was it, the wrong patient? The I got to be honest, Bob. I mean, if you're tolerating apixaban and have been so for years, how are we going to reduce bleeding? That seems like a stretch goal. There was a sub study that showed that, the real difference was in those people with a naive start to the drug. So that's a big unanswered question.
Yeah, I think there's still a lot of unanswered question. My own personal nickel down has been on the dosing issue. One of the things we know about milvexian, again, that you and I are both working with, is that we know it prevents clot at the doses that were studied because there was the classic DVT study in the total knee replacement patient. Those data have been published. So, a lot of indirect comparisons we're making here. The trial of milvexian and AF is still ongoing, and so we'll see in the years ahead. Mike, let's switch to 2025. Obviously, a new administration in Washington, new leaders of the FDA, new leaders of the NIH, new leaders of the CDC, all new leaders of CMS. So all of the things that affect the lives of those of us working in healthcare, working in science, working in biomedicine. Lot going on. You run a research institute. You're a practitioner. What are you thinking about?
Well, first of all, I'd like to say thank you to the outgoing FDA Commissioner, Rob Califf, who did an amazing job coming back for his second term, by the way. Thankless job, tough job. And, Rob and I talk a lot about it. One of the biggest problems, and it's still an ongoing problem, is misinformation. I think it's something we've got to really tackle head on. It's a very tough issue. I've been on the phone with several cardiovascular societies about this issue. There's a balance. If you shut things down and don't give people a voice, that's not a good idea. If you make it a democratized approach, well, there will be misinformation. So the question is, how do you counter that? And do you quiet people's voices Or do you allow people to have greater voices to overcome the misinformation? I was naive, 20 years ago when I created Wikidoc, an open source textbook, copy left, give everyone a voice, democratization of information. This is going to be great. Well, I was naive. There's plenty of people out there who will put up the wrong information. And so
Yeah, there's some bad actors out there, aren't there?
we're a bad actor. So I've come around to understand that the wisdom of the crowd isn't always wise, because you have some very loud people who may not always be right. Sometimes they're right, but sometimes they're not right. We have to have curation of medical knowledge. I think that's why we still do need experts, but we need debate. The other thing is doctors are very concerned about their safety, on these kind of sites, social media sites. I'm here today to announce, first time publicly, we have built a Twitter clone. We're about to release it around the time of ACC. It will be largely for healthcare professionals or people interested in healthcare. It's going to be a little different. You're going to say who you are and what you're interested in. Like, I'm a cardiologist. Then you're going to specify, here's who I like to talk to. And you could say patients, other cardiologists, regulators. Then you're going to specify, I want to hear from other cardiologists or whoever. That way you can make it clear what filters there are, who your voice goes to, and also what your ears are listening to. So we want to, our tagline is going from credibility to care. We want to, have credible information. We want to hear voices, but we want to make sure that we're vetting things. We will have some moderation, light moderation, but we're going to welcome everyone to that community. People are leaving Twitter, going to Blue Sky. That's a general platform, but we think it's time to have a platform really dedicated to healthcare professionals.
Healthcare and science, Mike, or
Healthcare and science, because those
Okay.
two go together. I also want to say a word about AI. I'm very concerned about AI. I would urge everyone to read the book Nexus by Harari. Here's the premise: we are storytellers, and the best storytellers prevail. And you don't even have to see the person; you can just be told a story virtually now, and it can be very powerful. And what has happened is, in democratization of all the information, as we said, some loud voices are being more heard. I think ChatGPT is going to largely replace textbooks. I mean, look, I write a big textbook, 106,000 chapters, and I can see when I use ChatGPT, the answers are pretty good diagnostically. What I do notice is that sometimes on the treatment side, ChatGPT doesn't really get it right sometimes. We don't know why it's spitting out the wrong answer. We don't know where to intercede to get the right answer. How do you tell ChatGPT, no, that the guidelines say this, not that? So I think we're going to have some better approaches to the treatment side of AI and some human curation there.
Yeah, so there's a lot wrapped up in what you said, and I'm excited to explore your new social media offering. I want to make sure that I continue to do a couple of things, which I do. That I've stayed on X, as you know, and you've stayed on X. I've opened a Blue Sky account. I haven't posted because I don't want to just be surrounded by voices that agree with me. I want to be surrounded by different types of voices. One of the beauties of Twitter in the early days is it introduced me to a lot of people that I had never met before and who offered opinions contrary to mine. And that was exciting and that was interesting. And I learned a lot. For me, probably the biggest thing of X that I've lost interest in is the complete lack of civility of some people. I don't mind being criticized. You don't mind being criticized. You and I debate things all the time, but do it in a professional, civil, respectful way. The way that people are addressing other people is it's just wrong. It's just wrong. And that lack of civility really bothers me. And maybe that's what you're referring to with some light moderation. You mentioned our mutual friend, Dr. Califf. I think the longtime listeners know that you and I are longtime friends with Dr. Califf. It really pained me for a guy that gave up a lot of what he was doing to try to take on this public service role. The vitriol some days that's heaped upon, hey, I don't agree with him all the time. and I'd love to, debate him about some of those things. But I know that he's a smart, data-driven, high moral value guy, and just to listen to some of the garbage that people heap out there is really bothersome. It's disturbing, and I hope that in a platform for professionals, Mike, people will act professionally.
I agree. I didn't leave X. I'm not going to leave X.
No, nor am I.
The problem I see is, as you said, the word professional. The data is the data, and let's stick to the data. That's great. I love debating the data. I'm a professional debater, but I I don't think we should go into personal attacks. I get attacked a lot. I just kind of let it roll off my back. But I think for some other people, it's really upsetting, really
Yeah.
devastating, and it leads
Well, I'll
to
look forward. What'd you say? ACC? We're going to see this?
yeah, yeah. So stay tuned.
Fantastic. Can I book Heart Bob H now so that I can still have that?
I reserved it for you. Yeah.
Couple more things. The nominee for HSS Secretary, Mr. Kennedy, he's talking a lot about focusing the country's attention on health and prevention as opposed to disease or in addition to disease. Not a bad idea. I mean, we talked in our last segment about GLP-1s and this intersection of obesity with all these diseases. That's something I'm certainly behind. I mean, a focus on the preventable diseases, a focus on heart disease, a focus on the inflammatory disorders, cancer. I mean, important stuff.
I agree. Here's the problem though, Bob, and I've been sharing in this space a lot about wellness and wellness apps, and wellness is kind of boring. How do you engage people who are well? That's one of the big challenges.
Yeah.
And so I think the approaches that I'm seeing are most successful are gamification. Here you are, here's your counts, your step count today, here are your calories, here are all your metrics. Here's a leaderboard. How do you compare with everyone else? Those kinds of rewards that seem to really be important. So
And particularly for people that are a little competitive like you
yeah,
and I. As you know, I'm a big Peloton rider,
right,
and if I'm gonna break my weekly streak, if I, look at
right.
my data, I compare it to people that I'm competing against that day, and, yeah, I get it. Gamification, we like that behavioral feedback
Right.
as human
A
beings.
lot of this comes down to behavioral modification. It's not science. A lot of it's
Yeah.
psychology. The other thing is, when it comes to wellness and even sickness, we're really going more and more direct to the patient, and they don't want to come in, they don't want to park, they want to do as much as they can virtually. They want to know daily and manage their health frequently on their own. And I think you're going to see a lot of efforts towards empowering patients, giving them those metrics. The wearables are unbelievable now. There's a company, Bena AI, pulse, blood pressure, cardiac output, cholesterol, LDL,
Yeah.
glucose, hemoglobin A1C, CRP, leukocyte count. It's all going to be on a ring, on a ring. You're going to see an explosion in the management of that data, but the real thing is that engagement.
Yeah, no, you and I are involved with some of the wearables, both from a consulting perspective, but also from a research perspective. And there was a company a few years ago at the AHA at the Health Technology Forum, and they're talking about a wearable that can measure troponin. You and I are involved with a wearable 12 lead EKG derived from through vector cardiography. And so you get your 12 lead EKG, you got your troponin, you got your symptoms. Wow, diagnosis at home, helping that probabilistic examination that goes on every time you say, well, does it sound like angina? Do you have angina in the past? Do you have any known coronary disease? What does your EKG look like? What's your troponin look like? And then we start to categorize people. Boy, this potentially makes it a lot easier, doesn't it?
A couple of years ago, I published a single lead EKG AI detection, 95% accuracy of a STEMI. So if we can get down to a single lead and spit in a cup and look at your troponin, or you get on your wearable, your troponin. And Bob, the other key thing is getting away from the word STEMI, getting to occluded MI.
You and I did with Manesh Patel, did a podcast on this that the remarkable work that some folks have been doing to really help us decide, is it likely that the arteries are occluded or not? I'm with you, Mike. I thought that was a fabulous discussion we had. And then the post-show pickup that had on social media was also great to see, because
Yeah,
people were just in the question, like, how can we figure this out?
right. But that's where I do think, AI and machine learning will come in handy.
Mike, this has been a fabulous conversation. I want to thank you for a look back into 2024, maybe more importantly, more interestingly, a look forward into 2025. We covered a lot of ground today. My guest today on Medscape Cardiology and the Heart.org has been Mike Gibson from Harvard, Boston. He's an interventional cardiologist at the Beth Israel Lahey, and he's the CEO of BAME Institute. Mike, thanks for joining me here on Medscape Cardiology.
Thanks for having me. My favorite day of the year.
And finally, I want to look at you, the audience, and say thank you for tuning in. And if you like this podcast, please take a moment to like, subscribe, or even write a review. It helps others discover the show. We want feedback, positive or negative, and suggestions for future guests and topics to cover with people like Mike. So thanks for listening.